And now that I remember to do that, we can go forward. Well, howdy, everybody. Even as a retired person, for some reason, I'm looking forward to the weekends. Like yesterday was 4 hours of meetings. There'll be 4 hours of meetings today. And so you breathe for the weekend, just like you were a working person. But I'll start with my mantra, who's got a case to discuss? Jay was just saying that we had a good discussion. I was wondering if Jethro was going to show up this week. I want to thank him for covering rounds. Jeff Barnes and I were goofing off last weekend or last Friday. So, not last Friday, but the Friday that Jethro took over. And Jethro, I was just mentioning before you came on that I wanted to thank you for hosting the RRR session a couple of weeks ago. Much appreciated.
I appreciate it. I'm just glad people came back. I'm just glad people came back this time.
No, I've heard good comments already. Good. But who wants to discuss something today? And Jay and I just had this big discussion about it. You guys have to speak up now because I'm not in the trenches very commonly anymore. I'm not seeing new patients. So you guys have to bring the patients to the discussion here. I do have one horrible catheter story I could tell you about later on, but we'll save that for if there's no discussion or if at the end of the session. Nobody, huh? There's no extracorporeal going on out there.
Jay put his camera on. That's good.
Again, I have a question for the group. I think we've had one or two potential hemoperfusion cases that were cats, and we just were struggling to get catheters in that would allow us the flow. I don't know if anyone else has any ideas or tricks or is there sort of a kind of understanding if it's under 7 French, good luck, you're not going to get any flow? Is there a limit to what size catheter we feel like we've been able to trick some of these platforms to sort of work on? Because I think we're just trying to be realistic for our ER teams in terms of advising them what animals are really candidates. And so, we have had some cats whose body weight in KIGS suggested they would be okay, but their vascular access said absolutely not. So I didn't know if anyone else had successful tricks or anyone has kind of the smallest catheter that they were able to get a reasonable flow that a machine would tolerate without just immediately clotting, because that's been our experience with the 2 cats we've tried to take on.
Well, we started doing cats in about 1993, I think, something like that, maybe a little earlier than that, and thought that would be a problem, and so I've never had a cat I couldn't get a catheter in. In fact, I'm not sure I've ever had there's only been one patient, and that was about a year or so ago. And now that Cedric just joined, he'll keep me honest. We did have one patient down in San Diego in my entire career that I couldn't get a catheter in. Otherwise, could always get one in. But you may be not always going to get one in transcutaneously. So that's the issue. And where we started, because when we first started doing cats, the only catheter that was available was an 8 French. And at that time, it had just come out. It was an 8 French, and it's my favorite catheter, actually. I'm not sure if it's a Medcomp or who makes it, but it's a nice round 8 French catheter that has kind of a stepped end on it. And it's silicone. And it's been my favorite catheter always. But it's not gonna go down that cat vessel transcutaneously on every cat, because most of the time that catheter is bigger than the vessel. But that doesn't mean you can't get one in, but there are some tricks to it and there's some techniques. I think the smallest catheter that you can effectively use, a double lumen catheter that you can effectively use for dialysis or hemoperfusion would be a 7 French catheter. You get smaller than that, and you're just not going to get reasonable flows. We have done single needle with a 5 French double lumen catheter, but in that case, what we combined both of those lumens into one lumen and then did it with single. In other words, we used a Y piece and then did it as a single needle treatment. I think you could use a 5 French single lumen catheter. Those will give you pretty good flows, but you'd have to be able to do single needle dialysis in order to get a 5 French catheter to work for you.
But we use the 5 French in that particular cat that you talked about, because that's the only thing that we could get in, at least at the beginning. That was a 5 French double lumen that we used as a double lumen. But the best flow we could get was 20 to 25 mils a minute, and that made us miserable for quite some time.
With a 7 French catheter, you can get 30 or 40 mils a minute most of the time. And in an 8 French catheter, you can probably get up to 60 mils, sometimes even a little bit more than that. But you know, I wouldn't bet on a 5 French catheter gonna do it for you. Now, the trick with a bigger catheter, with either a 7 or an 8 French catheter, again, a lot of times those catheters are bigger than the vessel normally is, and so you have to push them down. You have to push them down the vessel, and you're not going to be able to do that transcutaneously. You have to do it surgically, and you have to do it with a tremendous amount of patience, because it usually goes millimeter by millimeter by millimeter by millimeter. And I have special little tricks that I do, and we all learned this. We learned this decades ago when we started doing cats in the 90s, and the only catheter we had was this 8 French silicone catheter that was that effective. And there are a couple of, so you have to make a venotomy. You have to cut down on the catheter on the vessel. And then you have to strip all the fascia off it. And the nice thing about jugular veins is they're pretty tough and they're pretty hardy structures. And in a dog, if I'm going to do a surgical, a dog's not so bad. A cat, if you piss that vessel off, it's just going to vasoconstrict and you'll never get anything in there. And a horse is the same way. You look at a horse vessel cross-eyed and it's just going to vasoconstrict. So we always use lidocaine on them right away. As soon as we get in there, we lidocaine them, just drip some lidocaine on the surface. And that helps them relax a little bit. And then you've got to strip all the fascia off. Otherwise, if you go to do a venotomy or you go to even put a needle in, you may just get into the fascia and not get into the vessel, the lumen of the vessel. And on a dog, that's really easy. You just take some umbilical tape, you wrap it around and you just stretch it out like that. And that nicely strips all the fascia off. You couldn't do that in a cat. That vessel would just close down on you. So you have to meticulously, and I use little tiny Adson forceps, and you have to meticulously peel all the fascia off of the vessel until you get down to just the vessel. And then I make a venotomy incision. You could probably pass a wire down at that point. That helps. The other thing that you need is you need stiffness, and so that if you have a real flexible catheter, you're not going to be able to push it in, particularly a silicone catheter, because it'll as you try to push it in, it'll bubble up and expand. So you need a stylet in the catheter, probably a stylet and a wire. So get a wire down the vessel right away, and then you take a single layer of a 4x4, a moistened 4x4, because your fingers, the vessel will just slip through your fingers as you're trying to push the catheter through the venotomy. But if you have a single layer of a moistened 4x4, then that provides enough resistance, and you have to hold the vessel just tight enough that it'll allow the catheter to flow past your fingers, but not so tight that it's going to restrict everything. And then you have to, and sometimes they'll just go down. They may not go down transcutaneously, but you get the venotomy And if you get them quick enough, and if you get lidocaine on the vessel, then sometimes they'll just feed down. But if they don't, then you have to kind of just push them straight. You can't push them at an angle because they won't go in that way. You have to get absolutely straight with the vessel, hold it, and push the catheter down. Two things will happen then. You'll get the vessel will start to roll up like a nylon stocking might, as you put it on. And so that's going to cause a band around the venotomy area that's going to cause resistance. And so every once in a while you have to cut that band. And then that opens the vessel up again, that now you can push it down again. And usually a cat, it takes about 15 or 16 centimeters to get the catheter down to the heart. And you have to be patient. You can't force this, you can't rush it. You just put steady pressure on the catheter while you're holding the vessel, and it'll just very, very slowly move down. And then every once in a while you might flush through the vessel to expand it a little bit, but you can get them in. And so, we've never had an animal we couldn't get a catheter in and we couldn't dialyze. So that's kind of the answer to your ER question. We haven't done cats as small as 1.2 kilos, but we've done dogs, 1.2 kilo dogs. So, I would say that's getting close to your limit. But that might be something you practice once in a while. Maybe if you have a cadaver, you need a fresh cadaver if you're going to do it with a cadaver, because if they were frozen or something, the vessels wouldn't behave the same. But two things are important, or maybe three things. One, you have to strip all the fascia off the vessel, and you need to get a long length of vessel. So you need to get 2 or 3 centimeters of maybe 2 centimeters of vessel length, because you need to have enough room to grab it, and you need to have enough room to manipulate it a little bit. Get all the fascia off it. I usually use an 11 blade and then do a venotomy. So you pick the vessel up with your Adson forceps, and then you just do a tiny venotomy and then get your wire in. And you need toothless Adson forceps, and those are those little tiny pointy ones that with no teeth on them. And then you carefully tear all the fascia off of the vessel. And if you have the fascia on there, you're not going to get the catheter in. And then you make the venotomy, and you could do it with a needle. I've usually preferred to just use a number 11 blade and make a careful venotomy. I tell you, loops also help if you've got surgical loops, so that you can see everything. That particularly as you get older, that's a big advantage. I usually put some kind of a ligature around both ends in case the vessel breaks. They almost never break, but in case one did break, you'd want to be prepared to be able to ligate it. Usually it just contracts and will spasm closed. But and what really works nicely is that those little vessel ligature things. So they're kind of a stretchy material that you put around the vessel, and then you can sometimes better in dogs than cats, but the cat vessels, you've got to be as quick as you can, because they'll just vasoconstrict, and you've got to get lidocaine on them right away, otherwise they'll just constrict, and you'll never get them in once they spasm down. I mean, that's a big problem.
Yeah,
so that's my technique, but
very helpful. We learned that lesson of the vasospasm the hard way, because once we got the vessels into trouble, we could get a 5 French in, but that for our hemoperfusion, it wasn't gonna do it. And I think it's that debate of, we're used to sort of doing the transcutaneous methods for these like toxicities hemoperfusion, right? Because you're only going to use it once, and so that's that debate of how surgically aggressive are you for something that you're hopefully going to have to just use one.
Life and death. It's life and death. So
yeah,
you can't get the catheter in. And I usually use one vessel until I can't use it anymore. And so rather than switch to the other one, I'll work on one vessel. And if absolutely that one's not going to work, then go to the other one. And you usually don't get into much trouble with that. There'll be enough collateral circulation generally, as long as you get the catheter out. With dialysis, with just one vessel, you might get some head swelling later on, but as you got that catheter down, in the vena cava. But yeah, so these are good things to practice. I can often get a catheter in quicker with a cut down than doing it transcutaneously. So I'll usually allow myself 2 or 3 because I'm not as good as some people at getting that needle in the vessel on the first stick. And so we've got some of our technicians that are better at that. And I'm not afraid or embarrassed to say, Sean, can you come over and put the needle in or put the wire in, because they're just better at it than I am. But I can often do a cut down faster than I can do a transcutaneous catheter placement. The big problem you get into is if it's been stuck and now you've got a hematoma. The other big trick is identifying the vessel in the middle of a hematoma. That takes practice to know what the vessel looks like, where it's likely to be anatomically. And they're very distinctive when you see them. And so you're just doing blunt dissection, usually through about a centimeter incision. You're doing blunt dissection, and they have a very characteristic look. They're kind of this purplish structure, and they have a little bit of a glisten on them. And once you see them, you can see them. Then you identify them, but you have to know what they look like in order to get them and isolate them. And then you have to be able to isolate the vessel. And so usually, once I found it, then I blunt dissect on both sides, as wide as I can, top down. So you're going from the top down, just dissect one side, then dissect the other side, so that you can get a curved force up underneath it. If you just try to grab it, it won't go. You just get a big meatball, and then you have to dissect it out of the meatball. So it's much better and much less traumatic to bluntly dissect with a hemostat each side of the vessel until you've got it free on both sides. The only thing that's not free is the bottom, and then you can put a curved hemostat underneath and get it up. So those are the tricks that I use, but it's real helpful that, very, very often, I think most trainees these days never learn to do a cut down. Probably critical care they do, but an internist would rarely be daunted enough to do a cut down. But it's really helpful skill to know if you're going to do extracorporeal therapy, because sometimes you just can't get a transcutaneous catheter in, or you'll stick and never get the vessel. And you might stick it for 30 minutes or just poke at it for 30 minutes and never get a flash, where you could be in there and have the vessel out in 2 or 3 minutes.
Hi, I was just going to say something. At Penn, we have a fair amount of experience putting cat catheters in, and I cannot take credit for this, but it's based on our interventional radiologist specialist kind of developed a technique. Because I think the difficulty sometimes can be getting that 18 gauge catheter in with the 7 French and the 8 French. So what we do a transcutaneous approach most of the time. We will do it under fluoroscopy, because in cats, the wires sometimes go crazy places. Yeah. But if you don't have fluoroscopy, I think that's okay. What we do, and maybe Jay, it would be best if you just email me and I can tell you the technique, but we basically do a serial dilation approach where we place a 22 gauge catheter, I believe, or a 20 gauge catheter, and then we don't use the dilators that come with the dialysis catheter initially, because those are like 6 or 7 French. So we'll start with a 4 French, and we'll dilate up to a 6 French, and then we kind of have to exchange the wires. So that's why I would have to write it down for you to understand my technique. But we basically serially dilate up to the size of the dialysis catheter, and then we're able to get it in, because we found that it starts with that 18 gauge catheter that people just can't get that in. And just like Dr. Calgill was describing, like the cat jugular is very, very small to accept that, 7 or 8 French dilator immediately. So the serial dilation is a game changer for us. We never do cut downs. I've never seen one, actually. So that would be rare for us because this technique works so well. But if you want to email me, I can further describe it to you because you have to buy some extra stuff like a vascular access kit and the extra dilators and the extra wires to have on hand.
Yeah, that seems great. What's funny is we sort of do that with we have drum lines that you have to get a 20 gauge to get the drum line in, and so our nurses figured out they could get a 22 in most these are like peripheral catheter long lines, and then they would work their way up to the 20 gauge and then get the drum in. So that makes a lot of sense, but I think that's a great way to do that. So I will definitely take you up on that email offer.
And then Jay, were you saying you got them in, but then you're having flow and clotting issues with them? Is that what you said?
Well, we could get a 5 in, but it like the machine, like it just was like, this is too slow, and would, the pressure alarms went off, and it would, like, we really tried because we did have 2 different cats, and again, we didn't take some of these creative approaches. This is probably what we needed to do, but it sort of seemed like without a 7 in, it wasn't going to happen on our platform. So I was just sort of curious if that was a universal feeling, like if you don't get the 7, you're not doing it, because we're trying to not set up the machine and charge the client for some of those expendables if we don't get that sort of access from the get-go. And so we had a few that we got the 5 in. I was like, well, let's see what we can get away with, and it was very clear very quickly that was not going to work.
Yeah, you'd have a hard time, I think, doing dialysis or hemoperfusion with a 5 French double lumen. The other thing that you need to watch out for with these catheters is for example, I don't remember the brand. Maybe it's not Medcom. Maybe it's an Arrow, the 16 centimeter, 7.5 French. They have 2 different catheters. You want catheters that have the same diameter channels, and they've got one that's like and I don't remember the French size now, but you'll have so much resistance if you don't get the ones where the 2 channels are the same size. So make sure that you do that and watch that. Otherwise you'll have so much resistance you just can't flow through it. And it's usually the smaller one is the inlet side. So
both the 7 arrows don't have the same size lumen. You used to be able to get 1 7 where the distal lumen was bigger than the proximal, and then another 7 where the distal was smaller than the proximal. So depending upon the size of your animal, if you thought you were going to put in the caudal cava, then you might have chosen the one where the distal lumen was bigger because that was going to be your access. They're not making both of those styles anymore. The 8 French Arrow is the one that has the same size lumens for both, but the 7s are always different. You're going to have a 14 and an 18, and you only have options to have one or the other. So right now, I think the only ones that are easily available are the ones where the 14 gauge is the proximal lumen and 18 gauge is the distal lumen. Those are the only ones that are available.
They're sometimes a pain in the butt to use. Good discussion. Anybody else have any insights on putting in big catheters in small patients? I'd say the same thing about the horse, though. If you're going to do a horse, those vessels are very reactive, and even you have a horse vessel that's that big, you look at it cross-eyed, and it's gonna go down to microns instantly. Well, I can show since we're on the subject of catheters, let me show you a catheter issue. Fortunately, this wasn't mine, but was my well, before I show you, so this was a hemoperfusion patient as well, and the person who put it in is pretty experienced at putting in catheters, but she was working all alone. She called me to see if I could come in, but I was probably out goofing off, and I actually didn't get the phone call. I didn't hear the phone ring, and she was having catheter problems, and it would go and it would stop and it would go and it would stop and it would go and it would stop. And she had very slow flows on a pretty good sized dog, I think about a 10-kilo dog or so. And she could only get 30 mils a minute of flow on an ibuprofen intoxication. She finally, and this was also in the middle of the night, I think she worked from about midnight to 6 in the morning doing this treatment. And finally got the 10 blood volumes of treatment done and quit, and wondered, what could have been the possible reason for the catheter problems. And I said, well, there are a bunch of reasons, but you need to get an x-ray. And she was antsy about charging the client for an x-ray after the treatment was all over, before she pulled the catheter. And I said, you need to know why that catheter didn't work for the next time. And so probably the easiest way to understand why the catheter didn't work is to take an x-ray, just a lateral x-ray of the dog. And I said, go down, beg the radiologist to do it pro bono for you, or use some TA funds or something. And anyway, she did, and she sent it to me, and this is what she had. Am I showing that screen? I'm probably not showing the screen yet. Let me find out how to share here. Share this guy. So this is your worst nightmare. So what do you think about this? I think there are a couple of potential issues here. She knew it was a long catheter. So this was a 24 French catheter, 24 centimeter catheter, rather. 11 and a half French, 24 centimeter catheter that she was trying to probably get down into the caudal vena cava. It didn't get there. And I just see something. I was going to make a statement, but I would have had to retract it potentially. And so I'm glad I didn't make that now. But obviously, this is the reason that she and JD's going to be on this, and he's going to say, I told you, you always have to do these with fluoroscopy. You always have to do these with fluoroscopy. But at midnight, we're not going to get fluoroscopy. But I actually thought that this was down in the ventricle, and because of this angle. The atrium, if you go to a radiologist and you've got a catheter that comes down and goes way down here, they'll say it's in the ventricle. Well, the right atrium in a dog it's a pretty big structure, and it really goes almost down to the bottom of the heart. And a lot of radiologists don't know that anymore because they don't do contrast studies very commonly anymore. In the old days when we did contrast studies, you could see that real easily. But the other thing that might warn you that it's in the ventricle is this angle right here. So if it's in the atrium, usually the catheters will come off with a fairly shallow angle, go through the valve, and then go deep down into the atrium. When they come off and when they make this kind of an angle and they go down very quickly, that's often because the catheter went down the ventricle. And there's no problem with that. I mean, we get them there every once in a while and they work. The pressures tend to be a little bit higher, and you might worry that you do some damage to the valve. But if you've got a catheter and it's in there, you get away with it for a few days until you get it replaced or repositioned. I was going to say, I thought this one was in the ventricle and then wrapped around in the ventricle, but now when I see the tip here, way out here, it's probably not in the ventricle, probably is in the atrium, but just didn't make it, got down here, got twisted and got stuck, and then developed this big ugly kink. I would almost bet that it's a polyurethane catheter. This is what polyurethane catheters do. And so practically the only time that we ever use a polyurethane catheter these days is if we're going to do a single treatment. And, because these catheters will always get kinked, and the kinks get a memory in them, and they just kink and kink and kink and kink, and you never get flows out of them. But that was a horrible catheter story. And she'll probably yell at me for showing this, but since she's not here, don't tell her. Any other horrible catheter stories while we're on horrible catheter stories? Nobody? Anything else then? JD's got a patient there, it looks like. Maybe we can get, if he's still in the room, he could tell us about that case. Since we've got to waste another 28 minutes.
I've got either oh, Callie's putting something in the chat there. Maybe Callie's got something. Catheter in the carotid.
Catheter in the carotid.
Oh, I'm sorry. That was a message to me. I'm sorry,
No,
Callie.
it's okay. Now, hey, now you've thrown me under the bus. Here we are.
Now you have to share. Now you have to.
No, we actually had one that was in a horse, so probably not quite as interesting to this group. But we had the hemodialysis catheter, which I placed, and it was in the appropriate location. But we return to another 10 gauge often, and the person placing the 10 gauge, I was like, oh, to me that looks like it's in the carotid, and they were like, no, it's fine. Started hemoperfusing the horse while we were returning deoxygenated blood back to the carotid, and the horse looked at us and passed out.
That's really interesting.
So that was kind of my be careful to not put them in the carotid if you're doing large animals.
In the olden days, in the real olden days, when we first started doing dialysis, we used arteriovenous shunts, and so you'd have arterial blood going back into the vein. There was one dog that we had. It was a dog that belonged to that was finally adopted by one of our dialysis technicians at that time. Just a lovely dog. And we were doing chronic dialysis on it for months and months and months. And at that time, we just kept losing access. And so we went from one jugular vein to the next jugular vein. We finally ended up putting catheters in the femoral veins, and we ran out of every single vein. And we decided, well, we needed blood access, and so we thought, well, let's use arterial access. That's not a good option. And this dog so we had a catheter in some artery, probably the femoral artery, and every once in a while the dog would just space out. And there was a big clot that went to the brain. There was an infarct, and then it would wake up from that, and that would happen time and time again. And then we finally just decided that wasn't a good idea, and we needed to quit. So don't put those catheters in the arteries, at least if the flow is going to go backwards.
Luckily in horses, you just give them like a 5-minute break and they find their oxygen and they pop back up and don't care after that is what I learned.
Well, it was the same with these little infarcts that they were getting, but they just go blank, and then about 5 minutes later they'd kind of wake up. Jethro, you said you had a patient?
Yeah, I've got a couple I could talk about. We've had a couple of IMHAs that we've treated recently, and I've got an AKI. So I could talk about an AKI that we're currently treating. We just treated we're about a month into that one.
So now I guess it's IMHA. I'm into IMHA.
IMHA. All right.
You need sharing capability.
Yeah, and I'll start this one off.
Let's see.
An egg on my face story as well that I'll share with you guys, and then dive into the IMHA. Oh, there we go. All right, share. Let me put this into. So I don't know if you'll remember this cat, Dr. Calgo. This is a cat named Lucky, and this is actually at UC Davis in San Diego. I went there to visit in 2012 and spent a couple weeks working with you guys. And this cat named Lucky was
This is in the old days when we were putting cats in paper and cardboard boxes. Now we at least use an airline carrier shaft shell.
well, he's in the background of that one. He's in that half shell at least. But this cat, speaking of cut down, so this cat was pretty sick. Had I forget his degree of azotemia, but he had some
Oh, we're
congenital.
doing a gizmo treatment on this cat.
Yeah, yeah. And he was pending kidney transplant. He had some vascular anomaly that had led to his kidney injury, and he was a pretty sick cat. I was there for his first treatment, and so pretty, out of it, tended, and not very engaged, interactive. Didn't have much personality, um, which seemed great. So I was there as a visiting resident, and one of the nurses was there, and we had what I thought was we locked eyes for a second, and I kind of was excusing myself. I needed to pop out and have a bio break real quick, and I stepped out thinking we had made the exchange, and I came back a few minutes later to find that the table where Lucky had been, he'd been harnessed, was getting his gizmo treatments. He was not there on the table, but a little puddle of blood with his extracorporeal catheter still attached to the machine on the circuit, but no cat, sitting there on the table. And a commotion in the back in the water treatment room, and this kind of trail of blood spots all the way along. He had become suddenly aroused and excused himself from his harness, ripped out his jugular catheter, and run to the back of the clinic and hidden in the water treatment area. Meanwhile, this circuit was fairly substantial volume of his blood was sitting there with no cat attached to it. So needless to say, I certainly the folks that were there, and the good Dr. Ross was one of them, never let me live that down every time we would get together again.
It was your fault.
It was all my fault. But very, you're calm, cool, and collected. We actually gave the Lucky back the blood from the circuit through a peripheral catheter that he had. And so we were able to maintain that. But then it took a pretty extensive cut down surgery, and lots of swearing, I think, under your breath, as I was watching you try and regain IV access for this cat to continue to receive his treatments. And after that first one, he earns all of these boxes and the airline carrier and a lot more safety mechanisms in place. And I held my urine for all 6 hours or 8 hours of his next treatment. Didn't dare even step 2 inches away from the table that time.
Well, this is rule number 3. Rule number 1 is asepsis, asepsis, asepsis. Rule number 3 is thou shalt always attach the catheter to the harness. Now this cat probably wiggled out of it, but usually we'll get a trainee and they're pretty cavalier about, well, I don't really need to secure this catheter until they have one rip out. After they spent hours after hours after hours getting the catheter in, and then the cat jumps up and pulls everything out. They get the religion that you attach that to the harness. My suspicion was that the harness in this cat wasn't tight enough, and he wiggled out of the harness, and the catheter was attached to the harnesses, and everything got left with the harness.
Oh yeah, the catheter was still attached to the harness, just no cat attached to the catheter.
You have to be, it usually takes an event like that before you get religion enough that you really make sure that that catheter is going to be secured if the animal starts to get rowdy. Well, thanks for sharing that nightmare, Joe. I really appreciate that.
Glad I could spark some good memories from almost 15 years ago now. But in this one here, he's actually in a cat bag there. That's what that red is, and this cardboard is the.
And that brings up another issue. These cat bags are great, and I love putting these cats in a cat bag, particularly if you got a cat that's just as restless or fussy. And at Davis, the techs are always, "Ooh, it's cruel. You shouldn't do that." But you put them in a cat bag, they're comfortable, they're secure. They usually just go to sleep. The cats like it better, and then you've got complete control of the animal. And we put them in the cat bag, run the catheter back out the top of the cat bag, and they'll sit there for hour after. Once in a while they'll pee in the cat bag, and you have to deal with that. But It's a way of really, and the same thing will go for a tiny dog, a puppy or something that you need to get control of. Put them in a cat bag, and then you've got good security. The animals don't mind it as much. They feel like they're secure, and it's a great tool. And if your techs yell at you, override them and just tell them this is fine, this is fine. It's not cruel and unusual punishment.
Yeah. Well, that was a little blast from the past. Let me get to the actual TPE stuff here. Sorry, it's part of another.
So you keep all these 15-year-old memories around on slides and things.
Oh yeah. Oh yeah. These are the ones that all the good stuff, that those get buried by other things, but the ones that go poorly, those are the ones that are burned into the memory here. I'm one of those guys. I like to share with my trainees and colleagues and everybody else.
Your disciples.
Yeah, all the things that I've done wrong. So hopefully somebody doesn't have to repeat the same stuff I did, and then have a good chuckle about it too in the end. Don't have a ton of time, but I can tell you guys about Kaya. She's a 3-year-old female intact Weimaraner, who we met with a pretty advanced degree of IMHA, and she came to us from another clinic, and this was, as we're kind of building up our referral base up in this area. I was pretty excited about this dog because they reached out to me on day one, actually, that they had her at another specialty hospital a couple hours away and said, hey, we just met this dog with IMHA. You came and talked to us about TPE. Should we refer right now and get into start TPE with her?
That answer is yes.
And the answer was, well, she hasn't seen any meds yet. She hasn't even needed a transfusion yet. But as soon as she crosses that threshold, then yeah, absolutely send her down to us. So I gave him I said, give it a day before we venture down this financial commitment end of things. But I said, don't wait too long. So this presentation, I put a little bit of IMHA stuff in here, but from the consensus statement and JVIM, all the diagnosis of IMHA. She came to us with spherocytosis. She had a positive saline agglutination test that persists with washing. And so she certainly fit all of the categories of diagnoses for IMHA from a standpoint of the anemia, and then all the greater than or equal to 1 signs of hemolysis. She had hemoglobinemia, hemoglobinuria, erythrocyte ghosts, the whole deal. So very classic picture. Diagnostic for IMHA. We did our usual investigation, knowing all the potential associative causes of IMHA. And so we worked her up, to the nth degree. All kinds of tick testing was negative. Investigation for other areas of infection, also all negative. Ultrasound of her internal organs, abdomen, thoracic radiographs. No signs of neoplasia. Other obvious inciting causes. No recent drug administration or vaccines. She was intact, but hadn't had a recent heat cycle that the owners knew of anyway. So there was that kind of tickling in the background as far as her nature is being intact. But on day, we'll call this, I don't know, day -2, before she came to us, they called me up and said, hey, we're just about to give her that first transfusion. They diagnosed her with all the classic signs, and her bilirubin was 1.4. And that's when I had that conversation. I said, listen, I'm happy to go down that road. And I actually consulted with the owners. We had a nice conference call with both the veterinarians at the other hospital and the owners on board, and kind of went through, prepared them for everything to expect as if we were going to go down the road of TPE. And so they were prepared the next day when she didn't hold that transfusion, required another one, and her bilirubin was starting to climb, in the face of they'd already started the typical treatments for her. So it was nice that way because they were ready. It wasn't like they got to a point of, man, we're failing multiple transfusions and things are going really bad. I don't know, if these owners would consider referral, but having the conversation ahead of time was a nice way to lay the groundwork in this case. And kind of, felt good with the referring community to have them think about it on day one. So I was excited about that. So as she, a day later, she came to us, prepared for TPE, and still had all the same changes on her CBC, in saline agglutination positive, serocytosis, all those things. And at this point, her bilirubin had screamed up to almost 60 milligrams per deciliter. She'd gotten her third transfusion. She came into us at 8%. And so before we could start TPE, we did give her another packed red blood cell transfusion there. And let me get to the next slide here. And so we placed, she, yeah, I was happy with the placement too. MedComp silicone, 11.5 French, 24 centimeter catheter, right jugular. And her first, let me just get this out of the way here so I can see. She's about a 40 kilogram dog with a blood volume at that hematocrit of 18%, which is what she was after the transfusion of 3,100 mils. Calculating out her plasma volume, we got her plasma volume at 2,545 mils. And so our first treatment here, we use the Prismax membrane-based TPE platform and circuits, which has 157 mils in it. We did have our Thermax unit in here, so that added another 27 mils to the circuit. But in the dogs that can accommodate that extra volume in the extracorporeal circuit, we've been very happy to have that as a tool. So get to the next part. So I do the math for, in this dog, our first treatment, I did some calculations to try and approximate a 1.5 plasma volumes exchanged. By the time I calculated how many bags of frozen plasma and fresh frozen combination that was, and all the rest of it, I ended up with a volume that was 1.35 plasma volumes of exchange, and that was, I was happy with that. We did have a little bit of her red blood cells remaining from the transfusion before getting on the platform. And so we did add that 83 mils of packed red blood cells just at the very end of our replacements to bolster her hematocrit a little bit more at that point. So and again, I'm a disciple of all of you guys, but my replacement in this dog was about 10 mils per kg of synthetic colloid earlier on in the treatment. So my approach would be to think I'm taking that back out again, hopefully to try and avoid the potential for any kidney issue there. A total of 1,700, almost 1,750 of fresh frozen plasma, and I believe that was 6 units out of our blood bank. So I kind of find I'm aiming for about half of my plasma volume exchange as a plasma product. And then
are those double units or like 125 mil units?
You know what they are? They're variable. So don't tell my blood bank folks this, because
ours are variable too. And
yeah, some of ours are like 320 mils.
yeah.
Some of them are 240. So they're kind of all over the place. So I go through our -80 freezer and I sort through and pick out the largest bags of plasma I can, but they're technically double units. So 50% plasma and then the remaining as a synthetic, or sorry, isotonic crystalloid.
And JD just informed us recently that you can't, they're not manufacturing any synthetic colloids anymore in the United States. Have you been able to get a hold of some, or?
Oh, interesting. We must have them on the shelf. We've got a fairly extensive warehouse supply.
He's not in the room there, but we were in a meeting the other day and he said that they haven't been manufactured in Europe for a while. And now in the United States, he said that they're no longer manufactured in the United States either.
Oh, interesting. Well, curious, even the veterinary formulation of the Voluvin. Okay, interesting. All right, so that was our first treatment, and as I'd mentioned, I'm usually aiming for about that 1.5 plasma volumes exchanged in my first treatment. But if I have a smaller patient that I can get away with more plasma as replacement, I'll kind of push that a little bit. Kind of depends on the math of the volumes of replacement fluids I've got by hand. But just kind of trying to aim around that 78% decrease in the pathogenic substance. And this is my worksheet on my prescription form. And I'm going to show you what it actually looks like in real life here in a second too, because I'm curious to have feedback on if other people are as, I don't know, I feel like I'm a little bit crazy when I do the replacement. So I'll show you what that looks like too. I do plan ahead. I calculate my replacements and my at different blood flow rates to make sure I've got a table of different. Never quite sure what the different blood flows I may achieve. I kind of plan ahead. So let me get 4 or 5 different blood flow rates. And at that blood flow rate, I back calculate what is a safe replacement rate to maintain that filtration fraction down around 20% or so. So I do this ahead of time. So in the moment, as you know, things aren't going well with blood flow or something's happening with the catheter, me or one of the people on the team have the numbers to be able to punch in, and we're not doing math on the fly. And then I always calculate my protamine doses in these guys as well. And I've taken, and I think a lot of us do as well, but I run my calcium gluconate CRI whenever we're giving any citrated product back as replacement. In the past, I would kind of follow ionized calcium and chase it if I needed to. And I kind of got to the point of just go ahead and I start the CRI anywhere from 0.5 to 1.5 mils per kg per hour. And then kind of track it with that as well and make sure that I'm keeping up with that ionized hypocalcemia that comes into play. So yeah, so this is what my sheet in real life looks like. So I'm putting myself out there for whatever feedback and critique here. But if you look here, this is my table on my prescription sheet. I've done the math on this side to figure out how many 1, 2, 3, 4, 5, 6. So this was 6 of my units of plasma, and you can see the volumes are anywhere from 280, 235, 258. I get my 10 mils per kg of a synthetic colloid and then back calculate the rest as a balanced crystalloid. And I start with a little bit of head of starch at the start or synthetic colloid to give some oncotic volume to the patient while I'm taking out the plasma and replace it with something with some a little bit of osmotic support, because I've watched on my crit line as that prime in the circuit, if it's an isotonic crystalloid, redistributes pretty quickly once I've started taking plasma out in the first 10, 20 minutes or so. And I've seen enough, hypovolemia, hypotension, or signs that we've got impending with a change in the central venous oxygenation. Maybe the heart rate goes up a little bit. So I theoretically think, well, let me give a little bit of synthetic colloid at the start. And then my words, I start trying to like sneak in as much of the inexpensive crystalloid here. And so I go back and forth a little bit. Okay, how did the patient do over the last 10 minutes in terms of my crit line? How much redistribution of that replacement volume in their IV space is going outside, redistributing outside of the IV space, and causing changes in central venous O2 or watching my crit line show more hemoconcentration. And then I'll get a little bit more of the synthetic colloid in there. And then I start introducing the plasma. And I try and hold off on the plasma for at least a little bit of replacement volume so that I'm not giving this valuable commodity of replacement fluid and then just taking it, potentially taking some of that away again. So you can see it's a little bit, back and forth, fresh frozen, a little bit of plasma-lyte in there, fresh frozen, plasma-lytes. And these decisions are based on what my crit line is showing me and what my patient is showing me. And then I try and save, if I'm going to use any packed red blood cells, more towards the end of the replacement side of things, depending what their hematocrit is doing. Certainly if they're more anemic earlier on, and I feel I'm going to use some packed red blood cells as replacement, I'll introduce that before, this is the very last replacement fluid I gave this patient. So I'll pause there for a second and see if anybody's got comments or feedback or thoughts about how crazy the sheet looks.
It's a good sheet.
I was going to say, Jethro, this is Drew Taylor from MedVet. The sheet looks very helpful, and I was wondering if you might be willing to share said sheet.
Yeah, absolutely. If you want to send me a quick email, jmf 439@cornell.edu. I'd be happy to send it back over for you.
Thank you very much.
No worries. So this this sheet combines, there's some teaching in here because I use this with my house officers and other disciples, as Calgill would call them, to try and give some information about how and why we're getting to the prescription that we're getting to. And then it also forms a prescription sheet that my technicians and other folks that are helping me set up can kind of follow along with, in terms of getting the heparin boluses and prescription from that perspective. The ionized or the calcium gluconate CRI, I've got that in there at 1 ml per kg per hour for this dog. And then, as I said, I calculate a couple of different blood flow rates for replacement rates. And then I know this one's, I said, okay, well, if that's 25%, I'm going to try and stay, below that as best as possible. And then variable, in this dog, I did give diphenhydramine to prior to treatment. And then this helps me as well, my hep lock for after treatments. I've got my lumen volumes on there, so I know what I'm gonna need to hep lock those guys with.
How many treatments did you do, and how'd your dog do?
Well,
in the next 3 minutes.
Oh yeah, we got 3 minutes. Well, perfect. I'll just end with this couple of tables here. So we did 3 treatments for this dog. And you can see here on day 1 was our first treatment, 1.35 plasma volumes. The next day, we came back and did a second treatment. Her hematocrit held that day. She didn't need more blood products before our next treatment. She still had agglutination. Her billy was just budged a little bit, but her CRP had cut down by about 2/3 there. Once we had her on the unit for the second treatment, where we exchanged almost 1.5 plasma volumes, her crit was low enough at 16, and I was planning to take the next day off of treatment, and I didn't want to have her get a transfusion in between. So we took a single unit of packed red blood cells and used that as a replacement at the end of the second treatment. Got to day 3 and she was negative for agglutination, which this is like my favorite day in these kids is when they reach that day 3 after 2 treatments, and a lot of them are agglutination negative at that point, and it warms my heart. I show this to everybody in the hospital. Look how great this modality is. Her bilirubin was cut in half. CRP was still coming down. We gave her day 4 off, and her hematocrit was holding at 25. She still had some spherocytosis. She was still, strongly regenerative. We did our on day 4, we did our third treatment, another 1.5 plasma volumes. She did really well for that. And following that, our clinical pathologist kept saying there's a very small amount of agglutination. I'm like, what does that mean? But a lot of times they're negative for agglutination after that third treatment as well, and don't tend to look back from there. And you can see her bilirubin coming down really nicely, and her CRP kind of static from the treatment before. And after that third treatment on day 4, she was discharged and continued to maintain a static hematocrit. It was climbing a little bit, and we rechecked her a couple of days later, static. Agglutination had resolved. We changed out the hep locks on that 3-day, and then gave her a couple of more days and came back for a recheck and pulled her jugular catheter at that point. And on recheck, and she's rechecking with the internal medicine team and her regular vet, she's not looked back from that point on, and is maintaining, and in fact, doing thriving really well with a static normal hematocrit. Still has some signs of regenerative response. So I am interpreting that as she still has a little bit of red cell destruction potentially, or at least she's activated, but has not looked back from there. So because I know Dr. Calgill likes the bags instead of my tubes, there's just a nice picture of the sequential plasma bags that we used for her. And that was her with her plasma exchange certificate.
Well, thanks, Jethro, for sharing that. Any questions? That's the typical story. Every once in a while, you'll get an animal that does drop between treatment 2 and 3. if they're really horrible, they'll often do that. And so sometimes I do three treatments in a row. But that's also our typical strategies. We do day 1, day 2, and then skip a day and do day 4 or 5.
Just to math out all that plasma, so that was about 18 double units of plasma to do those 3 treatments, more or less, given your plasma
Took me
volumes
the
that I was looking at.
3. Yeah, we 6 the first. I think I might have squeezed treatment 2 and 3 as 5 double units each. So 16 to 18 double units, yeah.
Big dog takes a lot of plasma.
At Renal Week, I was interested to see the folks, and I don't think we have them come on the calls too often, out in Arizona at AVEC, are doing a lot of their TPE without any plasma replacement. And they're doing it over a much longer treatment period of time. But they presented a poster at the conference that was interesting to see. I'm not sure I'm that brave to be able to go down that pathway.
Well, one of the problems with that is that you need to replace some fibrinogen at some point. So if you're doing the treatments consecutively, you get an 80% reduction in fibrinogen each time you do one of those 1.5 plasma volumes of exchange. And you do that over several consecutive days, and then pretty soon you're not going to have any fibrinogen left if you don't give some plasma back. Usually if you have a weekend or so it'll build back up, but if you're doing consecutive treatments, you probably need to add some plasma at some point, or measure fibrinogens so that you're safe. If you're starting with a 50 fibrinogen and you drop it by 85%, you're in risky territory. Well, great. Well, another great session. Thank you all. Thank you again, Jethro, for the last RRR session and for your contributions this time. And we'll see you in a couple of weeks.
Take care, everybody.
Bye.